Good morning, everybody. Antimicrobial resistance is the pressing need of this hour. It's a global challenge, and antimicrobial stewardship is one of the important strategies in combating antimicrobial resistance. To speak on this, we have Dr. Priscilla Rupali. She is an avid researcher and infectious disease expert. Post her MD medicine at CMC Vellore, she did her diploma in tropical medicine and hygiene at the University of Alabama. She is a specialist advisor for the Cochrane ID group and the methodologist for the WHO guidelines on echinococosis. She has more than 20 years of appointment and teaching experience in the field of tropical medicine and infectious diseases. Her prolific research works encompass HIV, enteric fever, staphylococcal meningitis, malaria, extrapulmonary tuberculosis, and antibiotic stewardship. She was an indispensable member of the COVID-19 Indian Guidelines Formulating Group during the time of pandemic. She is the well-deserved recipient of several national and international research grants and has numerous international and national publications to her credit. This time over to Dr. Priscilla.
Thanks, Seema. I did not expect such a long introduction. Good morning, everyone, and it's a pleasure to be here. And as you can see by my T-shirt, we are going blue because it's the World Antimicrobial Awareness Week. So for those of you who did not participate in the marathon, you still have the chance to participate in a flash mob on Friday. So where we have our way of engaging the community. So my topic is slightly different in the sense that while we're going to be talking about medical education, how to be engaging the community. So we move away from the traditional modes of classroom didactic teaching to how to actually engage the community. So this is my rough outline. The epidemiology of resistance, which everybody's aware of. What is the use that we're talking about? What are the community engagement strategies? And a concept of smart regulation, which is coming into vogue, and some successful interventions in literature. So we know that antimicrobial resistance is one of the top threats to human health, and low middle income countries are actually affected by it. And unfortunately, these are the countries where the capacity for surveillance and management of drug-resistant pathogens is actually least developed. We know that there is a cost impact to it. And of course, there is morbidity and mortality attached to it as well. In 2019 alone, this is pre-COVID, about 1 million deaths were attributed to just antimicrobial resistance. And this figure is supposed to be, by 2050, is supposed to be around 10 million. So we're going to have a big problem on our hands. So I've just kind of put some of the data out there. So you can see how India actually has a huge problem when it comes to gram negatives. Luckily, gram positives, it's not such a huge problem, but we're heading there. So you can see here that we are like dark red for carbapenem resistance Acinetobacter baumannii on top. And then we are kind of orange for Klebsiella pneumoniae. And so we do have a huge problem. Now, what is really the impact of AMR compared to other diseases? And you can see here in the bottom panel here, in 2050, we will actually overtake cancer as well as one of the leading causes of death in the community. So antimicrobial resistance is going to be the largest cause of death in 2050 if we don't take steps. So this is the traditional stewardship definition, and I guess you can't start any lecture without this. So what is it really? It is an appropriate use of antibiotics by selection of the optimal antibiotic, correct dose, duration, and the route of administration. Now, you measure the impact of antibiotic stewardship by different ways. You can do it by measuring antimicrobial use. Generally, if you have to measure the impact on antimicrobial resistance, it takes quite a while. So a lot of people tend to use surrogate markers, and one of the surrogate markers is actually Clostridium difficile infections, which is what is used in most centers abroad. So this is antimicrobial use in the community. And if we have to actually use, when we are talking about human antimicrobial use, almost 80% of the antimicrobial use is actually in the community. And of that, about 20 to 50% is at any given time questionable. So it may be unnecessary or it may be questionable. So what can we really do, and what is really the use that has been described in the community? Now, if you look at the left side panel there, and when you compare the antimicrobial use in low middle income countries as compared to the high income countries. So you can see here from that graph over there, the high income countries, the use has kind of plateaued. So it has really not gone up. Then you look at the bottom graph and you can see how it is taken off remarkably, and you'll find that low middle income countries, the use has remarkably actually gone up. Now, if you look at the second panel, which is the bar diagram, and even if you can't see it, the tallest bar there is India. So just to say that India has actually a huge amount of antibiotic consumption as compared to most other high-income countries as well. Now, most of the time, we are worried about over-the-counter prescriptions, or what we call as a non-prescription antibiotics, or something that has not been prescribed by a physician. And there's been a lot of work that has been done by various communities, various organizations. So this is just country-level estimates of non-prescription dispensing of antibiotics. And you can see here, of the antibiotics that are prescribed in India, it's about 50 to 60%. We're still not probably as much as China, maybe not as much as Brazil, not as much as Central America, but we're still in sheer numbers and how it's going to impact us with regard to AMR, since we're the most populous country that really has wide-reaching implications. So this is antibiotic consumption across the country. And when you look at it state-wise, you can see here the statewide consumption, it's higher in some of the more affluent states. So obviously, antibiotics do have a cost attached to them. So the richer you are, it looks like the more you end up buying antibiotics over the counter. Now, we know that WHO, in an attempt to control antibiotic use, has actually classified the antibiotics into access, reserve, watch, and discourage. I wonder, we're all aware the aware group, but there is another group called the discourage group, where you basically discourage the use of these particular antibiotics. And these are irrational combinations that have been put together. So you'll find a variety of combinations that have been put together. And a list of them is actually available on the DCGI website as to what are actually discouraged. The access ones are the ones that WHO believes can be accessed by everybody. And the reason for this is traditionally, as a low middle income country, we've had issues with access to antibiotics. And I think we all know the story of antiretroviral therapy. I think somebody had mentioned that. And the Doha Declaration, and how we all fought for it. And finally, antiretroviral therapy became available to the world at large. So there's always this worry about, where do we draw the line, and do we make it accessible, and how do we actually control it as well? So we need to reach some kind of a balance. So this was an attempt by WHO to classify them. So access, watch, and reserve group. And you can see here, this is actually the use of various antibiotics in these categories by Dr. Anita Kotwani's group. And you can see here, there's a lot of antibiotic use with regard to discouraged group, quite a bit with regard to reserve group, and unfortunately, Tamil Nadu is there as well. And the watch group, so watch group is mainly Central India, and the access group is actually Gujarat and Kerala. So we have a lot of work with regard to that. Now, when we're talking about drivers of antimicrobial resistance, we know you look at the big circle on the right-hand side, human antimicrobial misuse and overuse is a huge driver for antimicrobial resistance. But apart from that, I think we need to keep in mind it's not just about a doctor in a hospital trying to prescribe antibiotics responsibly. There are lots of clinical, biological, social, political, economic, and environmental factors as well. So what really is the reason for antimicrobial use or misuse, let's put it that way, in the community? And of course, self-medication is one very important thing. And I know that those of you who've fallen sick and you tell your parents you're sick, and your mom is like, why are you not taking antibiotics? And you're trying to tell them, I've got a viral infection. Yeah, but use antibiotics will become okay quicker. So it's very difficult to actually convey the message that, it's a viral infection and you really don't need antibiotics to control it. We also have over-the-counter availability of antimicrobials, and in addition, lack of health education and awareness of how to use antibiotics appropriately. In addition, there is a lack of stringent restrictions to restrict antimicrobial use at the community pharmacies, at various other dispensing pharmacies that are close to us. A lot of economic factors which also contribute to it. I mean, obviously, if you just, go outside CMC, you will see like at least 10 pharmacies there. So there is an economic factor that actually contributes to it. And this poorly regulated antibiotic use is unfortunately a huge driver of antimicrobial resistance. Now, community-based interventions are all neglected in stewardship research. So it's, we all do stewardship at hospital level, but we forget that actually 80% of the misuse is in the community, and we really need to do something about it. So there is a mismatch here. So when you look at, AMS, 80% of the antimicrobial stewardship is in the hospitals and 20% is in the community. And those of you who have gone through an NABH accreditation will realize that, you can't get accredited till you actually have a functioning antimicrobial stewardship program. So a lot of driver to implementing stewardship has been accreditation, but then there's no such thing that exists in the community. So what can we really do about it? So this is a nice article in Lancet where they're coming across, where they have described how is it that we can move from the reserve group to the access group, and what are the various interventions that we can put in place with regard to this. If you look at the characteristics of the top 4 antibiotic classes, I think first thing you need to identify which are the antibiotics which are being misused, and then you put in place some kind of what we call as a smart regulation to take care of that. So these are the 4 antibiotic categories which have actually been widely prescribed widely dispensed across the community pharmacies. And you can see here, a lot of them are actually unapproved. So you see the dark blue column there, a lot of them are actually unapproved. And many of them are actually not included in the CDSCO list of approved formulations. So it's a huge problem, and it's something that we still have to work really hard to overcome. So this is a very interesting study where they kind of went out into the community and to high schools, and they just asked teachers and students, what do they know about antibiotics and antibiotic resistance? So just want to pay attention to the first line there. And so teachers and students both said that they have suboptimal knowledge with regard to antibiotics and antibiotic resistance. And teachers also mentioned that they want an instant cure. They don't feel like waiting, so they feel that if they take an antibiotic instantly, they're going to become better. They don't take full courses. They're worried about cost of medication once they go to the doctor. So it's easier to go to the pharmacy and just get a prescription and do away with the doctor's fees. So it's easier to do that. And when they ask the students, what are the themes? Why is it that you, take antibiotics? And they said that usually you consume it for cough, cold, diarrhea. So there are syndromes that are emerging where antibiotics are commonly misused, and we need to actually target those. When they ask teachers, have you been a patient and have you gone to a doctor? And what have they told you about antibiotics? And what the teachers said is that there was no counseling from doctors, and they didn't realize they were taking a risk by actually taking antibiotics. So that was not really explained to them. And they felt that there was also pressure from, their family members saying, you need to become better quickly. And they also felt that the doctors they did not really explain all the nuances with regard to antibiotic consumption. And sometimes, of course, the dispensing doctors are not really providing a prescription, and sometimes they just say, go and take this antibiotic, and they'll write it on a piece of paper where they don't really sign it. So we have a huge role to play as well with regard to appropriate use of antibiotics in the community. So what is it that would be an effective intervention? And it looks like from the literature that is available, and I'll show you some of the interventions that have been described, that multifaceted interventions which have a strong educational component are probably the most effective. So while we can do workshops, you can do seminars, you can do review and feedback in the wards, you can do all kinds of things, these tend to have a substantial impact when you actually broad base it. So you include everybody. So there's a lot of community engagement with regard to these multifaceted interventions, and that is the only way to make it successful. So there's been a lot of work, and these are some of so it's called CE, Community Engagement for AMR. And this is a network which focuses on tackling behavioral drivers of AMR at the community level. And the wonderful thing is it works only in low middle income countries, and they work to provide bottoms up solutions which are actually championed by the local people. So a lot of it is driven by, many, you can see here Dr. Soumyadeep Chatterjee is one of our infectious disease physicians in Calcutta. And this is a beautiful article where they actually looked at what would be the drivers in the community for inappropriate antimicrobial use. So if you can just pay attention to the topmost thing over there, and you can see extrinsic drivers for market environment. So a pharmaceutical representative coming to you, telling you this is a fantastic antibiotic, and it's going to kill all the microbes that are there. And then, of course, intrinsic drivers are informal providers who may not really have knowledge about, okay, this is the spectrum of this antibiotic, and you probably don't need it for the infection or the syndrome that you're trying to cover. Then, of course, communities and health systems, which actually promote AMR as well. And some time ago, I'll show some data regarding stewardship at secondary care hospitals. We've done a survey of secondary care hospitals and helped them implement stewardship in their hospitals. And what we found is, just for a simple thing like surgical antimicrobial prophylaxis, they did not have cefazolin available. And they were using vancomycin for the surgical prophylaxis, simply because vancomycin was freely available. And cefazolin was not available in any government institution in the Northeast. So simple things like this, and we don't realize how the health systems itself promote sometimes antimicrobial resistance, and that is why we need to pay specific attention to that. So apart from education and mass media campaigns and focus education and leaflets tackling syndromes. So we know that the syndromes which require appropriate prescribing are respiratory tract infections and gastrointestinal. Those are the two main reasons why antimicrobials get prescribed indiscriminately. And these are the various primary care facilities. When they've tried all this out, they found, apart from education, I think the one thing that could make a huge difference is point of care testing. So if diagnostics were available at most secondary or primary care levels, that could actually be a game changer. But of course, we have ways to go. COVID has been a blessing in the sense that a lot of PCRs are now being done at the community level. So could we leverage that and change it into something that would help us reduce antimicrobial resistance as well? So when you compare developing countries and developed countries, and apart from leadership commitment, which is really important for us, we do have a national action plan, and ICMR has taken a huge role in trying and implementing stewardship all over the country. But again, it's only restricted to hospitals. It's really not gone out into the community. We have a lot of lax regulations, irrational fixed dose combinations, questionable quality of medicines, which is again a huge problem for us. And of course, over-the-counter availability, which is a huge problem for us. And also intersectoral coordination is not there. So we should be working with the veterinary community. We should be working with aquaculture and the environment to be able to bring these out. We don't have diagnostic facilities. All our healthcare facilities are overcrowded. If you just go out there, you'll see it. We have compromised sanitation and hygiene. And a lot of places do not have true antibiotic treatment guidelines, which are based on local AMR data. We do not promote vaccinations enough. So if people were vaccinated more, they would probably be less inclined to take antibiotics. But again, vaccination has a cost attached to it. We do not have systems to monitor what is happening with regard to antibiotic consumption. So the hospitals and the tertiary care will monitor their consumption, but it doesn't actually happen in district levels. It doesn't happen at primary care levels. It doesn't happen even in the local communities. So any antimicrobial stewardship intervention that is there in the community is very patchily implemented. A lot of the time there is a hesitation to implement it. And there is an economic tag to it. I mean, which pharmacy will try not to give an antibiotic when they can make money by giving an antibiotic? So a lot of these things need to be taken into consideration, and it needs to be incentivized before we go forward. So a lot of community engagement um, um, networks have actually focused on few key concepts. And one thing that they're trying to focus on is that microbes are alive and antimicrobials are important medicine. So we often think we are like, okay, this is like, we all know it. But I think these are things that we need to bring into the community, simple messages saying microbes are alive, antimicrobials are important, and seek advice before you use this. There are lots of repercussions of using antimicrobials unnecessarily. And these microbes, because they're alive, they get resistant and they tend to overcome any other antimicrobials that may be available. So simple graphics, which kind of explains to them. So you have a man who has, a resistant microbe, and then he transmits it, or rather, he or the poultry defecates into the environment, and then everybody, all the other animals also gain these resistant microbes, and then that can be found in our fish and meat and milk, etc. So simple messages which are contextually modified to be able to be received by the community in a way that they can actually understand. So just this morning we had the marathon, and people won prizes. So one question that I had asked them to ask was, Abhi had asked, one of our consultants had asked, so what are you running for? Antibiotics. But they have no concept of what antibiotics means. So we kind of had to explain to them, you're running because you need to use antimicrobials responsibly. So simple messages are actually not getting through to our community. So we're hoping that with various community engagement interventions that will take place. So apart from education awareness, public health campaigns, now access to healthcare, what people felt was if there was appropriate access to healthcare, people would probably not use antibiotics unnecessarily. That is a thought. Will it actually happen? We don't know. So improving access to healthcare, advocating policy changes, and of course, participating in research actually makes a huge difference. Now, there are a lot of interesting things that have happened. Interventions through children in the community. So as part of the Antimicrobial Awareness Week, we're going to various schools and colleges as well. So what we're hoping to do is engage by social media, short films, stage play. I know our medical students don't have a talk on stewardship. I know postgraduates don't have a talk on stewardship. So what can we do with regard to integrating these key messages into appropriate use of antibiotics? Educating mothers who are caring for children, creative approaches which encourages young people to promote appropriate use of antimicrobials and important infection control preventions. So a lot of these, I've just put these here, and I would like you to look at the one in India. So it's called superheroesagainstsuperbugs.com. It's an amazing site. And it gives you animated cartoons, which you can actually just play in your outpatient departments. It's funny, it's engaging, it's colorful, but it provides simple messages to the community, which you can actually provide. So this is it. This is a program of Rockefeller Foundation. And you can see here, they have like very catchy slogans, very catchy pictures, very catchy videos. And they have, a protagonist who's like one protagonist who's terrible and one who's good. So that's what it's about. So these are all the challenges in the secondary care setting. We mentioned some things as well. So these are all the challenges in implementing stewardship on the left-hand side. But apart from implementing, I think sustaining it is always a big, big challenge for all of us. So whether it is universal antibiotic policy, encouraging people to take collective responsibility, it's not just, the infectious disease person or the internal medicine person. It's actually a collective responsibility, and trying to engage that is going to be important. So just to kind of, we had done something similar. We were like a hub and spoke model, which we, kind of did it at 4 secondary care hospitals. And we actually found a huge difference. We implemented an intervention which was multifaceted. It was a one-year blended learning program. We trained pharmacists and nurses to be champions. We helped them implement it. We upskilled their lab technicians. We created antibiograms for them through a program that was freely available and helped them develop guidelines. And we found a huge impact with regard to the antimicrobial use. So it is possible. It's not like it's not possible. And this was just picture of the various training that we had actually undertaken for implementation in these 4 hospitals. So one interesting thing I found was this concept of smart regulation. So what is this smart regulation apart from the traditional smart regulation? So what they felt was they get stakeholders together and they have like a first step, second step, third step, etc. So first step, when they kind of are non-compliant, you give them an educational program and, kind of motivate them and blah, blah, blah. So it's like a regulatory enforcement pyramid. So you first follow it up with education, then you have a warning, then you have a second warning, then you have a nominal fine, then go on to actually temporary closure with a higher fine and ultimately imprisonment. So the government is actually moving towards this smart regulation, and this is something that has been adopted in various other communities, shipping and other places as well. So all effective programs must prioritize education as a core component, but these education programs cannot be didactic. They have to have a multifaceted approach, and one of them is creating champions. So this is Antibiotic Awareness Week. So if you come at 7 o'clock in the evening today, you'll see CMC all in blue. This is the program that we conducted on Monday. You can see that it is multidisciplinary. Those are our nurses in our MTS2 ward holding a puppet show. This is, I think I have a picture of HICC. And of course, we had the marathon this morning. So thank you for your attention. And I don't know if I have time for questions.
I'd like to thank Dr. Priscilla for this lucid presentation. We have one question here for you. A lot of folks who started using sanitizers during COVID argue that that also kills bacteria. How is antibiotic use different?
Okay. All right, that's a tough question. It seems more philosophical than actually there. So, I mean, we all know, I never realized that it was in doubt that antibiotics do not kill bacteria. Antibiotics are commonly used, and here we're talking about a multifaceted approach. So it's not just about antibiotics. We're talking about antibiotics as well as infection control principles, as well as an educational campaign to control, to implement antimicrobial stewardship in the community. So it's not, I agree, hand sanitizers are absolutely important. And I think washing hands rather than sanitizers, that's also perfectly acceptable.
Thank you. Okay. Thank you very much. Once again, a round of applause for Dr. Priscilla.
I'd like to ask Dr. Hema to give the memento to Dr. Priscilla.